evening, everybody, and welcome to February 2025 and the first conversation with a doc for this year. We're very lucky to have Dr. Liana Rosenthal with us this evening, and I know so many of you have signed up for this and you've asked such good questions, and I know we're going to be we're lucky to have her. Before I turn it over to Dr. Rosenthal, I just want to add a couple of things. We're going to do something a bit different this evening. Instead of just signing off right away and turning everything off, and that's the end of it, we're going to put a short evaluation up on the screen. Please, please, please fill it in. I know you might not want to, but it is really helpful to us, and it's helpful to one of the funders who helps make sure that we can do conversations with a doc. So if you value these sessions, please do fill out the evaluation. I'd also very much like to hear from you all about what other kinds of subjects that you would like more information on, other topics. And with that, that's all I have to say, and I'm going to turn it over to Dr. Rosenthal.
Well, good evening, everyone, and thank you all so much for being here, and thank you to Judy for the invitation to speak with you all today. It is my pleasure, and hopefully we can have an interesting conversation, and hopefully everyone can learn a little bit about cognition and Parkinson's disease. So what we're going to be talking about is, first, I'm going to define cognitive impairment. We're going to talk about types and causes of cognitive impairment. And then we're going to actually talk a little bit about treatment of cognitive impairment. So that's the idea. And it can be a bit of a weighty topic. So I'm going to start with kind of broadly, and hopefully then we'll have lots of time for questions at the end. And then there are also actually some questions that I have for you during the course of the talk, where basically if I've done my job, the answer should be obvious. That is what I'm hoping, if I did my job correctly. So first, a little bit about cognition in general. So in normal aging, there is some decrease in cognitive function. And if you look at this graph, it always kind of makes me laugh because it basically says cognitive function is all downhill after about age 45 or so. That's basically what it's telling us. It's all downhill after there in terms of cognitive function. And the way this manifests is the things that we all know or that you all talk about. So you forget a word in the sentence, you forget the name of that actor in that movie, you walk into a room and you forget why you went there and what that's all about, you forget where you put your keys. It manifests in all those ways. And so we know that in normal aging, as folks get older, they don't do as well in cognitive testing. So what you're looking at here is age across the bottom here, and then you're looking at sort of a mean and average value of a different testing. And then all these areas here are different areas of cognition. And you can basically see that, you get a little bit better until you're around 45, 46, and after that, it's all downhill. That's basically what they're saying in terms of normal aging. I don't like to lead with that though, because there are benefits to getting older in terms of cognition and in terms of your life overall. And one of them is that well-being actually improves as we get older. So they're looking here at a measure of well-being. And again, it's age across the bottom, and then this measure of well-being, a self-reported well-being on a scale of 1 to 10. And even though your cognition may be at its peak around 46 to 50, they're actually saying that people's well-being is at its lowest around that time. And then it goes up from there. And I could come up with all sorts of reasons why this may be. So right now, right around the age I am, I have my kids, I have my work, I have my husband, I have my parents. There's a lot going on right now. And so I could completely understand that as one gets older, you are more secure in your job, you are more secure in all sorts of aspects of your life, and your well-being grows up. And I'm pretty happy right now, but I can understand how this may be. So while cognition may get worse, well-being improves as we all get older. And in addition, wisdom improves as we all get older. So here they're basically saying they started around age, early 30s or so in terms of wisdom. Certainly you can imagine that if you keep going down, you'll get like my teenager's wisdom, somewhere down there, and then you may keep going, right? And my teenager's great, but nevertheless, wisdom is not his highest, strongest suit right now. So you can see that wisdom keeps going up at a wonderful rate here. They have this wisdom score, and I don't remember how they valued wisdom and how they calculated it. But the bottom line is that as we get older, our wisdom goes up. So while we may not do as well on cognitive testing, our well-being and our wisdom gets better. So I just want to lay out that concept about what happens to folks who don't have Parkinson's disease as they get older. So now we're going to switch over in terms of thinking about, well, what about people who do have Parkinson's disease? And I think, as you all know, thinking difficulties are common in Parkinson's, and you all know this. About 20% of adults with Parkinson's have some kind of cognitive impairment at the time of diagnosis, and I'll define what that means in a bit. And overall, individuals with Parkinson's have about a 3 to 6 times greater risk of developing dementia than individuals who don't have Parkinson's. But importantly, some individuals never develop dementia. And that's true that some individuals with Parkinson's never develop dementia, even when they have had Parkinson's for more than 20 years. So it's not everybody. But nevertheless, we know these thinking difficulties are very common in PD. So what is cognitive impairment? What does that mean when we say this? And I'm going to read a couple of these slides because I think it's really important to think about the definitions and what it means. So cognitive impairment, changes to thinking or the processes involved in knowing or putting information together. And our cognition involves a lot of categories. So that can include attention, problem solving, memory, language, visual perceptual skills, reasoning, general intellect. If you think about it, we all know people who excel or not in one area or another. And all of those things are considered cognition. So we know people who are really good at visual spatial reasoning. They're really good at putting furniture together. They're really good at reading a map. And we know other people who are not so good at that, but they may be great at remembering numbers or doing math in their head. So we all know that there are these differences, and cognitive impairment are changes to any of those. So changes to thinking or the processes involved in knowing. And many patients will report slowness in thinking and word finding difficulties. So, because sometimes what can happen is it's not just each of these areas of thinking and memory, but also the processing speed, how long it takes you to get to the answer. So any of those things can be cognitive impairment. I'm going to define it a little bit better then on the next slide. So I'm going to define both dementia and mild cognitive impairment. So dementia are cognitive changes associated with absolute clear impairment in function. So in practice, what does that mean? How do we define that? That means the person does poorly on standardized tests. They may have trouble with their job. There are multiple examples in different areas of life where cognition affects your actual life. So that's dementia. Mild cognitive impairment are cognitive changes that are noticed by the patient and maybe others, but no definite impairment in function. So in practice, a person with MCI or mild cognitive impairment does worse than expected on standardized tests, but they still may function pretty well at their job and they still do well in most things. And as you can see here, we're defining the difference between MCI and dementia based on function. Well, it may matter what you're doing in your life. So if you're retired and your spouse has always handled the finances and your spouse has always been the one who's cooked all the food and your spouse has always been the one doing lots of stuff, you may not have that many cognitive demands on you that maybe you would have dementia if you were still working. But because you're not working and you don't have that many cognitive demands, it might be defined as MCI. And that's okay, actually. It's just a matter of how we think about and how we operationalize MCI versus dementia. And the thought is that people who develop MCI, mild cognitive impairment, are more likely to then develop dementia. So we know that these changes can be gradual over time. The other thing that happens, and the other thing that we need to think about, is there are actually many different types of cognitive impairment. And dementia or cognitive change can be due to a whole bunch of things. So Alzheimer's is sort of the one that people talk about. So patients will ask me, do I have Alzheimer's? Well, by definition, if you have Parkinson's disease, you don't have Alzheimer's. You can have Parkinson's disease dementia, but you don't have Alzheimer's. It's different. It's a different type of dementia. And importantly, people who have Parkinson's disease dementia, their dementia often looks different and acts different than people who have dementia from Alzheimer's disease. Same thing with people who have dementia from something like frontotemporal dementia or dementia with Lewy bodies. Vascular dementia, Huntington's disease can cause dementia. Traumatic brain injury can cause dementia. Something called CJD, or Creutzfeldt-Jakob disease, mad cow disease, can also cause dementia. Or you can have a mixed dementia. So, and the reason it starts to matter is both in terms of the cause, the treatment, the effect, what's the most effective in terms of helping the person who has this developing dementia. But then also it matters in terms of, we know that when we do cognitive testing on people who have Parkinson's disease and dementia, it looks different and it acts different than people who have Alzheimer's. So people who have Alzheimer's, the fear of a lot of my patients is they're not going to recognize their family. And that is not as common in Parkinson's disease dementia. You can have lots of other problems with Parkinson's disease dementia, but it's different. It acts different than Alzheimer's dementia. So with that in mind, a few more definitions for you guys. So, and this comes up, and it's a semantic point, but there is a difference between Parkinson's disease dementia and dementia with Lewy bodies. And I apologize for the slight semantics, but it matters in part because patients will say, well, I don't have Lewy body dementia, do I? And so here's the difference. People who have Parkinson's disease dementia means they have a diagnosis of Parkinson's disease for at least 1 year prior to the onset of very noticeable cognitive changes. So this is not the people who have some mild issues and then they develop a rest tremor and some slowness to their movement. And then 10 years later, they start to have a lot of issues at work. That's very clearly Parkinson's disease dementia. People who have dementia with Lewy bodies are people who develop symptoms of Parkinsonism and cognitive change within basically the same time, within a year of each other. So these are some of the definitions. So we've talked about cognitive impairment, we've talked about MCI, we've talked about dementia, we've talked about the fact that there's lots of different causes of dementia, and then the difference between Parkinson's disease dementia and dementia with Lewy bodies. And one of the things that's true of all of these things that we've talked about is it all follows this kind of standard idea of a preclinical phase, a mild cognitive impairment phase, and then a dementia phase. So what you're looking at here is a graph of time and then relative cognitive decline. And we all start out at normal. And you can see that when you're in the normal phase, it's people, and this person in the blue line here is kind of developing MCI. It's hard to tell right here, is this normal or is this the beginning of MCI? It's almost impossible to tell. And in this preclinical phase, there are brain changes without measurable symptoms. The individual may notice changes, but you can't really tell on tests. It's a stage where the patient knows, but the doctor doesn't. It's kind of what we talk about. So maybe that you notice a few things at work. You notice things aren't as easy as they used to be. But to be clear, that could be normal. It could be normal, it could be preclinical, and it's very difficult to say. Then you get to the point of MCI, and in the MCI phase, the cognitive changes are of concern to the individual or family. one or more cognitive domains. So either visual, spatial, attention, processing, one of those domains we call them, could be impaired, but you're doing well in terms of your activities of daily living. And then once you hit dementia, the cognitive impairment is severe enough to interfere with everyday abilities. And I can tell you, I have had patients who, when I do extensive cognitive testing, we diagnose them with mild dementia, and 5 years later, they still have mild dementia. So the decline isn't always quite as steep as this is making it look to be. It really depends on the individual, the person, and the reason for their dementia. So the idea, though, is certainly you go from preclinical to MCI to dementia. That's one thing to think about. Okay, so now we're going to pause and audience participation. So my loved one has had Parkinson's disease for 15 years and now has some problems thinking. He's still doing okay at work, not as sharp as he used to be. He must have dementia. Is that true or false? And you can put your comments. Oh no, you didn't see that. You can put your comments in the chat. So true or false? What do you think? I can't see. Can you see the results? Rhonda,
No.
Rhonda, you raised your hand. Are we able to unmute you? Or I don't know what we're able to do here.
Oh, let's see. Michael?
If he's not able, we're okay.
Oh my God, the computer's decided to go bonkers.
All right, that's
Oh,
fine.
wait, so Rhonda Barrett raised her hand.
And yeah, perfect. Go ahead. Rhonda, what do you think? True or false? You should be able to talk now, Rhonda.
All right, and my computer's decided not to.
All right. All right. Well, I hope everyone's thinking of the right answer. And the right answer is clearly false.
All right,
Yeah,
we
we're
had
not able to unmute,
people,
unfortunately.
2
All right.
people.
Thank you for raising your hand, but unfortunately, I can't see it.
Can you put it? Oh, they can't hear me.
Fred, did you have to say something, Mr. Miller?
I was just going to say that it's clearly false.
Perfect. Good. Exactly. That's the whole. Yeah, these questions should be obvious if I did my job. So that's the idea. All right. Well, thank you. There'll be more questions, and we might call on you again. Okay.
Okay.
All right. All right. So different areas of cognition encompass our daily needs. So the idea is that this is what I was talking about in terms of domains and these different areas of cognition. So executive function includes things like multitasking. And the truth is most of us are not very good multitaskers. So the truth is what we actually do is we scroll through all the different things and we think about all the different things, but we're not necessarily truly multitasking, and that's different. And then there's memory. So memory includes working memory, procedural memory. So, and the thought is that memory requires this optimum level of dopamine. So the idea is, of course, that if your dopamine is too low or too high, you may have some challenges with memory, excuse me. And memory can also be things like procedural memory, to acquire a motor or cognitive skill through practice. The classic one, of course, is riding a bike. There's also language, visual spatial perception, and attention. And all of these areas are the different domains and the way we think about cognition. And so when I ask in clinic, how's your cognition? I'm actually asking about all of these. So what causes cognitive change? Cognitive change actually happens for at least 4 different reasons in Parkinson's disease, that is. So there can be the Parkinson's changes. So what this picture is this is the Lewy body. And what that is it's a whole bunch of alpha-synuclein, which is the bad protein in Parkinson's, all glommed up in the neuron. And when it's all glommed up in the neuron, it causes problems. Think it's like a giant traffic accident on the Beltway. So that's the alpha-synuclein causing problems. So cognitive changes can happen in Parkinson's because of the alpha-synuclein in the brain. In addition, and where it gets complicated, is in folks who have Parkinson's disease, about 30% of them also have Alzheimer's type changes in the brain. So they have what we call amyloid and tau, the bad proteins in Alzheimer's. Those are also in the brain, and in about 30% of people. And what we know is people who have alpha-synuclein in their brain from Parkinson's, and everyone with Parkinson's, almost everyone with Parkinson's has alpha-synuclein. If you have alpha-synuclein and the Alzheimer's type changes, you are more likely to have cognitive impairment and dementia than if you just have the Parkinson's changes. So 1 + 1 is greater than 2. You can also get cognitive changes because of vascular and stroke problems. And then you can also have cognitive changes in Parkinson's disease because of a combination of all of the above. And if you had to choose, you're always better off having one thing wrong than multiple things wrong, because we know they add up and multiply and sort of feed in on each other. So now we've defined cognitive impairment, we've defined dementia, we've talked about how it gets worse, we've talked a little bit about the cause. But I want to now talk about what happens when you come to the doctor then and you ask him, your doc, about your cognitive change. What is involved in the workup? And even more importantly, I think, what about treatment? So the cognitive changes work up in treatment. So one of the things when a person comes to me and there's a history of cognitive changes, we're going to talk about the history. And then the other thing we also do is a reversible treatable workup. So I think about what is happening. Why is this person getting cognitive change? And sure, it could all be the Parkinson's, but there may be some other things that we can really do something about. And it's really important to tease those out. We also talk about neuropsychological testing, which I'll talk about. And then importantly, in treatment, in terms of treatment, it's the key things we want to prevent further decline as much as we can, behavioral modifications, and then of course, medications. So with that in mind, when a patient comes to me and they have cognitive changes, I think about history. So are the changes intermittent or continuous? Do they impact function? Are they sudden drop-offs or is it gradual? Sudden drop-offs may suggest stroke or a few other things. What other diseases does the person have, and what about family history? And each of those things kind of gives me some clues as to what I need to be thinking about them in terms of the workup. So these are some of the questions I'll ask if someone comes to me with cognitive change. In terms of the reversible treatable causes, so thyroid dysfunction. So if your thyroid is too low, too high, that can absolutely cause cognitive issues. Advanced syphilis can cause cognitive issues. Severe kidney or liver dysfunction, vitamin B12 deficiency, seizures, depression, hearing loss, sleep issues, which I did not put on there as well, should also be talked about. And those are things that we can do something about this. We can treat your thyroid dysfunction. We can treat your vitamin B12 deficiency. We may or may not be able to treat the kidney or liver dysfunction. We can certainly treat seizures. We can treat depression, hearing loss. We can help you sleep. So there's some things that we can do to improve cognition. So now I'm going to talk specifically about the depression and hearing loss, because I think those are really key areas that we can make a difference. So at least 40 to 50% of individuals with Parkinson's have depression. And depression can impact arousal, attention, concentration, obviously mood and affect, and of course how you perceive things as well. Depression can also lead to memory issues and language issues, and certainly personality changes. And the thing with depression is there's something that we call pseudo dementia. And what that means is the person doesn't really have dementia. They have pseudo dementia, fake dementia. And the reason they have this fake dementia is because they're depressed. And so the thing about depression, and most importantly, is while it can cause all of these problems and many more, it is treatable. So therapy has been shown to be effective in treating depression. Numerous medications have also been shown to be effective, and above and beyond helping your cognition, treating depression can also improve quality of life. And it's so important because this is something that we can do something about. Sitting here right now, I am unable to change the amount of alpha-synuclein, that bad protein in Parkinson's. I am unable to change the amount of alpha-synuclein in someone's brain. I can't do anything about that right now. But right now, we can help someone's depression and improve their quality of life and also improve their thinking, memory, and cognition issues. And that really is a remarkable thing that this treatment exists, and it's something we can do something about. The other thing that comes up really often is hearing loss. And so I want to really emphasize this slide, and the next slide is a little bit more confusing because I realize it involves, you have to understand hazard ratios and statistics, the next slide, but I want to show it to you for a couple of reasons. So what this is looking at here is years of follow-up. This is not people with Parkinson's, by the way. This is just all comers. This is years of follow-up. So starting at year 0 to year 18, and the proportion free of dementia. So in other words, 1 means nobody has dementia. All the way down here is 0 means everybody has dementia. And what you can see very clearly is that if you don't have hearing loss, for example, at 10 years of follow-up, if you don't have hearing loss, those people are much more likely to be free of dementia than the people who do have hearing loss. There's a very clear association there. And it likely has to do with the idea that when you have a hearing loss, you're not getting the same amount of inputs from the world around you. You're not able to pay as close attention, or your brain is spending too much time trying to understand what someone said rather than processing it and being able to respond. And so hearing loss is absolutely very clearly associated with development of dementia. But the next slide, I think, is an even more important slide, which is treated hearing loss. So what they're looking at here, and I apologize for the weighty statistics on this. I couldn't find a pretty graph that showed it, but I'm going to talk you through it. What they're looking at is 8,000 people who did not have any hearing loss. And those people had a reference of 1. So 1 basically means they don't have dementia. Let's just go with that idea. 1 means no dementia. People who have untreated hearing loss, i.e. they're not wearing their hearing aids, of those 1,000 people, they had a 20%, 1.2, that's what that means here, a 20% increase in developing dementia. However, people with treated hearing loss, people wearing their hearing aids if they need them, had only a 6% increase in dementia over the people who had no hearing loss at all. So while wearing your hearing aids are not going to solve all of your dementia problems, the point is it's really important because this is something that we can do something about. And I'm going to give you a few additional tips on this here. It's important that you go and get your hearing tested. It's important that you wear your hearing aids if turns out you have a hearing loss, you should wear your hearing aids. And a lot of my patients say that the hearing aids are really uncomfortable and the world is really loud. They put their hearing aids in, the world is loud, and it's very uncomfortable. And the reason it's very uncomfortable and you don't like it and everything sounds bad is that your brain is not used to hearing all of the sounds. Because, our brains naturally don't pay attention to the hum of the lights, the hum of the computer, the traffic outside, how loud it is when the TV's on, or whatever it may be. Our brain learns to kind of filter out those noises. And so the problem then is when you suddenly put your hearing aids in, your brain has to learn to filter out those sounds. And your brain also has to learn how voices sound now, how things sound now. And that takes a little time. So for some people, it helps. Wear them for an hour or 2 a day for the first couple days, then wear them for 2 or 3 hours, then 3 to 4 hours. You get the idea. And so it's important to wear your hearing aids, treat your depression, because both of those things can absolutely help with thinking, memory, and cognition. So now, the next audience participation question. We have a 65-year-old man who's had Parkinson's for 5 years. He's recently had worsening of his motor function and just generally not thinking as well as previously. He's been more irritable, more quick to lash out, and a bit down. His cognitive changes may be due to Parkinson's disease pathology, Alzheimer's disease pathology, depression, Parkinson's and depression, or all of the above. What do people think? You can raise hands again. I don't know what we're able to do here.
The chat's been enabled and I can't get myself out of
If
mute.
I go to chat, Miss Trulove, what do you think? Are you able to unmute?
I can't.
I can,
Oh, all of the above.
all of the above. Excellent. Excellent choice. Exactly. Thank you. That is the idea. Perfect. All of the above. Because it could be, and the key there was the word pathology. I could see some people were doing A and C. You're not wrong. But it's the pathology part. So we know that if you have Parkinson's disease, that is, we know that if you have Parkinson's disease, you have Parkinson's disease pathology, but some people with Parkinson's disease pathology also have Alzheimer's disease pathology, but they don't have Alzheimer's disease, but they have some of those bad proteins in their brain. So moving on in terms of our workup, in addition to assessing the treatable causes, we sometimes also do comprehensive neuropsych testing. And comprehensive neuropsych testing includes history, tests of baseline pre-disease and intelligence, and then also lots and lots of cognitive testing. You're asked to copy things, remember things, identify patterns, names, words, all of this. It is usually at least a 3 to 4 hour day. So neuropsych testing can be very comprehensive. It's a long day. It's a hard day. It's a tiring day. But the idea and what the neuropsychologists are able to do is they're really able to think about all of those domains, those areas of cognition that I talked about. They're able to think about and identify which of those areas people are having the most difficult time with. And that tells us something about the cause of someone's dementia or someone's cognitive impairment. So they may be able to point out, for example, that someone's cognitive impairment is at least being contributed to by depression. They'll be able to think about things like that. So that's one of the things that neuropsych testing can do. So this is an example of neuropsych testing. So they might have you look at this pattern and you have to figure out what goes in this box. Or you might have to, copy this figure. Or you might have to draw a line from 1A, 2B, 3C, that kind of stuff. So that's something that we can do in cognitive testing. So with all this in mind, what can you do if you are having some new challenges in terms of your thinking and memory? So obviously treat your depression, wear your hearing aids if you need them. Those are clearly things we've talked about. But I want to talk about some other compensatory strategies as well, and about keeping your brain working, basically. So what can you do to help? Work on one task at a time. I know it sounds silly because it's sort of an obvious answer, but nevertheless, it's important to reiterate. If you're having trouble multitasking, don't multitask. Work on one task at a time. In practice, what that often means is making lists of things to do. Because usually if you're working on a task, then someone interrupts you and then you lose track of where you are. You need to have a list of what you're doing and what you're supposed to be doing. So make a list and put those lists somewhere where you're actually going to look. That could be your smartphone, it could be your computer, it could be the kitchen, whatever. Be patient with yourself. This is hard. This is hard on everyone. The more you stress yourself out over it, the more difficult it will be. Maximize your function, get treatment for anxiety, depression that will contribute to feeling overwhelmed. And then, of course, use your smartphone. So the smartphone is fantastic as a reminder system for all sorts of things. I can tell you it's gotten to the point where my kids even will tell me, like, Mom, put a reminder on your phone, because they know that I'm going to forget like certain things. And so they'll be like, Mom, put a reminder on your phone. So you use your smartphone for a reminder system. My kids make me use my smartphone for my reminder system. And I have learned that by the time I get home, I'm going to forget to do X, Y, and Z. I put a reminder on my phone. And it can help us sort of organization. The other thing to do that's really important is to work on modifiable risk factors to prevent further decline. Weight loss if you are overweight, blood pressure, cholesterol management, diabetes management, see your primary care physician in terms of regularly checking for other contributors, heart disease, thyroid function, all of those things that I talked about that were modifiable. And I think it's important when you think about this is the idea is that treat everything else that's going around on, and that way you're sort of left with the things that unfortunately right now we can't do as much about. But that's the idea. And then really, really important, and I know my patients know this, is exercise. And the idea is if you are not currently exercising, to start slow. And if you are exercising, making sure you're optimizing your exercise. And I always like this slide. My doctor told me to start my exercise program very gradually. Today, I drove past a store that sells sweatpants. And my hope is that you exercise a little bit quicker than that. But one of the things I think that's really important about exercise is, in addition to being really good for the motor part of Parkinson's disease, it's also really, really good for the executive function, the cognitive part of Parkinson's disease. So what this is looking at here is 0 is considered how the young adults do. So we're going to say 0 is like normal, okay? So 0 is the young adults. You can see they did well, the young adults, on these cognitive tests. Then what we're looking at here in the gray bar, okay, are the high fit older adults. So 0 is good. And the further down you are, that means the worse you're doing on cognitive function. So we want to be as close to 0 as possible. So the gray bars are the high fit older adults, the older adults that are exercising. The orange bars are the low fit older adults. In other words, the older adults who are not exercising. And you can very clearly see that the people who are exercising are doing much better than the people who are not exercising. So in other words, these people here are closer to 0. The gray bar, the average of the gray bar here, is much closer to 0 than the average of the orange bar. And the idea is while we know that older adults are always going to do worse on cognitive tests than younger adults, we want you to do as well as possible. And exercise is one way that you can work towards that. The question always comes up of what type of exercise you should do. And the bottom line is anything is better than nothing. Tai Chi for balance, bike riding, gait, pool walking, something that you will enjoy. 30 to 45 minutes, balance and gait training, cardiovascular endurance. Something is always better than nothing. 10 minutes is better than 0 minutes. 20 minutes is better than 10 minutes. But something is always better than nothing. There are also a whole bunch of medications that we talk about, and I can talk about this more if people have questions, but there's a whole bunch of medications that we also can prescribe. Many of these are FDA approved. Some of them are off-label for Parkinson's disease cognitive impairment, but they're approved for Alzheimer's, but we use them in Parkinson's disease. And they're actually relatively helpful. They're more helpful in Parkinson's than they are in Alzheimer's, but generally there's not a huge benefit. They're not game changers, but they can help some people some of the time. And you're going to notice that I did not put on here any of those new medications for Alzheimer's. And that's because as of right now, none of us are treating our individuals who have Parkinson's disease and cognitive impairment with those new Alzheimer's medications. As of right now, for our Parkinson's patients anyway, they are considered too high risk and not enough reward to be worth doing for the Parkinson's patients. And there's ads for them on TV, I think. There's, if you read the newspapers, there's new ones coming out all the time. There are all these infusion therapies for Alzheimer's disease. We are not using them right now in Parkinson's disease. The risks are too great. The benefits are not yet known, or not high enough, or not clear enough. So right now, for the purpose of medication treatment for cognitive impairment and Parkinson's, is all these medications, plus all the other things I talked about. Treat your depression, wear your hearing aids, exercise, things like that. In terms of crossword puzzles, it always comes up. If you like crossword puzzles, and if you enjoy crossword puzzles, and if you enjoy the brain games and the brain teasers, by all means, sounds great. I have to be honest, it's only recently that I started getting into crossword puzzles, and they're only tolerable because I do them with my husband at night, and only the Monday New York Times. We're not good enough for Tuesday yet. And so with that in mind, if you told me like a year ago that I had to do crossword puzzles, that would have been awful and I would have hated it. And so if you don't like doing them, don't do them. It's not clear the extent to which doing those things translates to being any better in any other areas of cognition. But what is very clear is More frequent participation in cognitive activities reduces the incidence of dementia. Cognitive activities can be lots of things, though. Read the newspaper, play chess, visit a library, attend a play, stay engaged. That's the idea. And then address other things that impair involvement, as I think we have talked about. Most important question. I have Parkinson's disease and I'm worried about developing dementia. There's nothing I can do to decrease my risk. True or false? I hope the answer is obvious. In the interest of time and the time for questions, I'm going to say false. Yep, I hope the answer is obvious. And so in summary, cognitive changes are normal. They're often noticed in Parkinson's. There are many contributors to these cognitive changes. Depression, hearing loss, and a few other things are treatable causes, and exercise can improve cognitive outcomes. So with that in mind, thank you very much. I appreciate your time, and I'm happy to answer questions.
Okay, and we have a lot of them. So the first one is, some of this you may have gone over, but is there anything to improve cognitive impairment and dementia resulting from PD?
Yes, we talked about a lot of those things. There are certainly those medications that can help some people some of the time, and they're certainly worth talking with your doctor about whether or not they're right for you. The bigger things, though, are things like depression treatment, hearing loss treatment, making sure your other medical things are optimized, staying active and engaged in the world, all of those things.
What are the signs of cognitive decline?
The signs of cognitive decline that people talk about are, wait, back up. The ones that I worry about are the safety things. So these are things such as leaving the stove on, leaving the doors unlocked, getting lost while driving, although that's not as bad these days because most cars have GPS. As long as you can use your GPS, it's okay. The paying bills twice or not paying bills at all. Those are the things I worry about from a safety standpoint. Usually what people will tell me is, you know, I ask him something, he doesn't respond as quickly. Excuse me, he doesn't respond as quickly. He's just not as sharp as he used to. He used to be that we would watch a movie and we would talk about it, and I just don't notice it. He's just not as engaged in those things as much as before. We're at dinner and he's not following the conversation as much. Some of that can be hearing, some of that can be attention and cognitive change. And also certainly any problems at work. I mean, that's an obvious one. If someone is still working, that can come up.
My husband has been diagnosed with Lewy body, and I just want to understand more. Does this mean that he no longer has Parkinson's? Does he need to continue taking the medication for Parkinson's? It's a fine separation that I don't truly understand.
I don't blame you for not understanding it because it's a moving target the way we define it. So the bad protein in Lewy bodies is also this alpha-synuclein, which is the same bad protein as in Parkinson's disease. They're both synuclein diseases. And they both, the motor changes that you see in dementia with Lewy bodies are similar to the motor changes that you see in Parkinson's. So we usually have patients who have dementia with Lewy bodies take the same medications as patients with Parkinson's disease because sometimes that can help their movements. So even though it's not traditional Parkinson's disease, those same medications can help their movements. And the definition and the difference between Parkinson's disease dementia and dementia with Lewy bodies is really a difference of when the dementia began. Did it begin more than a year after motor changes, or was it pretty obvious around the same time as the motor changes? That's really the key distinction. There are a few other things that also distinguish dementia with Lewy bodies from Parkinson's disease, but the short answer is he probably does need to continue taking the medication for Parkinson's disease because it might be helping his motor function. But I would talk with your doctor and his doctor just to make sure you're all on the same page in terms of that medication. Is it helping him? Is it not helping him? What else should you be thinking about?
Do you have examples of individuals that have been able to halt cognition decline, if not actually improve it? especially via exercise? If you have any, please share, i.e., inspire your audience to make intentional movement a daily habit. Also, what medications are observed to be most effective?
So in turn, I agree with you completely. Here's what I have a number of patients, yes, who I will, so I was involved, and some of the folks on this call were involved in a research study that we followed patients for 6 years, and we did very detailed cognitive testing annually. And I can tell you, I had some patients who came into that who already had cognitive impairment, and 6 years later, their cognitive impairment has not changed. In fact, in that group of people that came into the study, even amongst the people who had what we defined as normal cognition when they started the study, if their cognition was going to change, and it did not change in everyone, but if their cognition was going to change, it changed from normal cognition to mild. No, I think we had one person go from normal cognition to dementia in that 6-year period. That's very rare for it to go that quickly. And what it's very clear to me is that the folks who exercise by far do better than the ones who don't. And this is true in research studies, this is true anecdotally, that the things that you can do to maintain your cognition are all these things that I've talked about. Exercise regularly, stay active and engaged in the world, treat your depression, wear your hearing aids, all of those things. And yes, absolutely, I have seen people who are doing those things stay stable for significantly longer. And if the issue was depression or not wearing hearing aids, I have seen people say, yeah, actually things are better now that my depression is treated. And things are better. Oh yeah, I'm much more engaged at the dinner table now that I'm wearing my hearing aids. So absolutely, I have seen people who are doing those things get better, and those who are exercising also keep things stable. So yes, is the answer to the question.
Okay, next one. Will the cognitive problems that patients with Lewy body dementia have continue to worsen or continue to appear off and on? After 5 years with Parkinson's Lewy body dementia, my husband still has off and on cognitive and memory issues. They occur more often when he's tired, but that's not always a trigger.
We know in Lewy body dementia in particular, one of those other things that I talked about that we see in Lewy body dementia is that the folks who have Lewy body dementia often have these moments of clarity and moments of being very unclear and much more cognitive impairment and the back and forth of it all. And that usually continues. What usually happens over time, and you can adjust slightly the speed of that decline, but over time, the amount and number of good days and good times goes down a little bit, and the amount and number of not as clear times, unfortunately, can go down a little bit as well. It can go up, I mean. And so you can see that in dementia with Lewy bodies. And that waxing and waning is really classic for dementia with Lewy bodies. But again, dementia with Lewy bodies is different than Parkinson's disease dementia. Because in Parkinson's disease dementia, you can still have some of that, those fluctuations, but they're usually not as pronounced. And so you can have those fluctuations. I think that answers your question. Did that answer the question?
I hope so. Can someone with Parkinson's disease also have Alzheimer's disease?
So if you have
Wow.
Parkinson's disease, by definition, no. Any cognitive impairment with Parkinson's disease is called Parkinson's disease-related cognitive impairment. But what you can have is, right, of course, why make it easy? What you can have is Parkinson's disease, cognitive impairment, and that cognitive impairment from Parkinson's disease can be caused by the bad protein from Parkinson's disease and the bad protein from Alzheimer's. But we would never call it Alzheimer's disease because it's not defined that way. And the reason the semantics slightly matter is it has to do with the problems that we would anticipate. That's the idea.
Okay, I'm not sure if you've answered this one or not. I feel like maybe partly, but I'd like to know the difference, if any, between age-related cognitive decline or changes and Parkinson's related cognitive changes and decline. Is the clinical medical age-related cause the same as the Parkinson's related decline?
So no, it's different. In Parkinson's disease, the clinical age-related decline is so let me back up. In Parkinson's disease, the decline is thought to be due to the bad protein in the brain. Whereas in age-related decline, there are lots of other causes and components to that. Dr. Smith, actually here on the call, she may be able to answer the general age-related decline better than I can. And she brings a excellent comment in the chat as well about animal models and the effects of exercise on the dopamine system. With more exercise, less dopamine loss. Exactly. So that's a great point, Dr. Smith. Thank you.
Next one. Does the presence of delusions and or hallucinations mean that the individual with PD lacks the criteria for being assessed as having capacity? What cognitive disruptions associated with PD alter capacity?
So if you have delusions and hallucinations, it does not necessarily mean that you lack capacity. Capacity is often a medical legal term, and is often is the question of, is the person able to handle their own affairs? And there's a legal definition that I actually don't have handy at this moment, in part because I'm usually not the doctor who is thinking about capacity or is determining whether or not someone has capacity. That tends to be something in psychiatry training. But the presence of delusions and hallucinations in their own right does not necessarily mean that the person lacks capacity. I have a lot of patients with mild hallucinations, intermittent hallucinations, and absolutely those are not that does not mean that they lack capacity. And I have people with mild delusions. It does not mean they lack capacity. But capacity is a legal definition, and that is something that the psychiatrists have significantly more training than I do in terms of establishing what it means and thinking about operationalizing whether or not someone still has capacity.
So I think you've answered this one, but we'll ask it again anyway. Do brain games really help with cognition? And what are some other ways to stave off this part of Parkinson's?
I think brain games definitely help. The more you do brain games, the better you are at the brain game. So there's definitely that part. So they help you at doing brain games. Whether or not, it's not clear whether doing those brain games translates to other areas, but I do think that it's very clear that being active and engaged in the world and doing brain things definitely does help with cognition. And if you enjoy the brain games, by all means, I would not recommend spending hundreds and hundreds of dollars. But certainly, if you enjoy the brain games, by all means, it definitely isn't going to hurt. And it may be fun if you enjoy it. And so it's certainly worth doing if it's something you enjoy. The key thing, though, is active and engaged in the world. Read books, talk to people, be engaged, and make sure that you are being all part of the world, and making sure that your world isn't getting smaller, that it's staying big, and that you're doing things and you're getting out of the house and you're engaging with the world. And if you like brain games, by all means, sounds great.
Please explain the stages of Parkinson's disease progression in references to cognitive effects.
Right now, the Parkinson's disease progression is not defined cognitively. It is defined motorically, so based on your motor symptoms. And right now, actually, the way it's defined motor-wise is not linear, by which I mean people don't spend, 3 to 4 years at stage 1, and then 3 to 4 years at stage 2, and then it goes on from there. It doesn't work that way. Most of my patients, when they come in to see me, are already at stage 2. And for almost the entire time that I see them, are at stage 2 or 3, and they can go back and forth. And because the difference only has to do with how good their balance is, and balance can get better. So the staging system right now has nothing to do with cognition. By the time someone has dementia, if someone gets dementia, we would usually define it as late stage, but that's kind of just a loose, I have folks who've had dementia for 10 years and they still come and see me in clinic and they're doing fine. So I wouldn't necessarily, we define it late, but it's the definitions are not very good right now. There's a lot of debate actually amongst the research community about changing how we define the stages, and cognition is now being included in this newer version of the staging system. But right now that staging system has absolutely not been adopted clinically and is a lot of debate. Every conference I go to, we're debating the staging system. So right now it's not ready for prime time in any way. But so right now we don't really stage it cognitively.
Can the loss of muscular coordination be reversed in people with Parkinson's?
So muscular coordination, it can mean all sorts of things. Can medications, exercise, and practice improve things like fine motor movement, walking, motor coordination? Yes, absolutely. Reversed is a strong word. Can we improve upon people's current abilities? Probably. Our goal is usually to optimize and not reverse. And I say optimize because we can't make any of us, the same as we were when we were 25, right? We probably,
why
I
not?
know, if only, we can't make any of us the same as we were 10 years ago. But what we can do is if you're not yet optimized, we can optimize medication. And I've definitely had folks where it's really important to them, their fine motor movements and certain things and their handwriting. And if it's really important to you, yes, you can work on it. I have folks who do a lot of crocheting, and I'm convinced that those folks, they do better on the fine motor tasks over time because they're working at it. They're using their hands regularly. And they're crocheting because they like it, but they're definitely working at it. It doesn't have to be crochet. It can be woodworking. It can be any of those sort of fine motor, visual, spatial tasks can be great. And definitely folks who exercise are doing better in terms of their motor work and their motor planning. But it's a matter of you can optimize those things. And yes, depending on how optimized or not you are, we can improve on your current state of affairs and how you're currently doing. But reverse is not quite the word I would use.
Okay, do neuroplasticity exercises like learning language, physical and thinking exercises at the same time help slow cognitive decline?
Yes.
Okay, that's that.
Yes, I'm making that short. Yes. I mean, we've talked about all the reasons why and everything up to this point. So yeah.
Oh my God, the computer's going bonkers here. Come on. All right, can you look into the chat because my computer,
So what I see here is I don't see any more. All I see are these things, these three.
nothing in the chat?
I don't see anything in the chat now,
Wait a minute.
but I don't know if I'm looking at the right spot.
Michael, can you see anything in the chat?
Yeah, we were just talking about asking about sending out the survey through email. Some people had to leave a little bit early.
yeah.
Okay.
Yeah, that I can say. But yeah, there weren't any questions in the chat.
Yep.
Okay, all right. Well, that's all the questions we've got. This has been terrific. Absolutely terrific.
Thank you
Remember,
for having me.
everybody, it is being recorded and it will be up on the website by today's Tuesday. It'll certainly be up by Friday and probably sooner than that, but certainly by Friday. So you can always listen to Dr. Rosenthal again.
That's what you always wanted, I'm sure.
It is,
Camilla,
actually,
did
yeah.
you have a question?
Fred? I don't know how that happened.
But yeah,
Yeah.
Fred just needs to unmute. There we go.
Okay. Now, can you also send out the other slides, not just the surveys?
Oh, the slides?
Yeah.
Oh, I can. My slide set includes like 69 other random slides, 69 other slides, but I can delete it and I can come from there. Yes, I can try to I'll try to send out just what I talked about. My goal was to keep it to 30 minutes, which I went a little bit over. I
Okay.
didn't want to have too many slides.
Remember,
I can
it will be available on the website, so you
Oh,
can
right.
always,
Okay,
you can
perfect.
always access it that way too.
Okay, yeah, I want to give it to my wife.
Yeah.
Um,
Okay.
Okay.
Okay, I mean, thank you again,
Thank
Michael.
you for
So
having
the,
me.
the survey is gonna come up as soon as we close this, I think. It's the first time we've done this, so we'll see if it works.
Yep.
Please fill it out. It's very short. I don't think it's gonna take you, it'll be less than 5 minutes to fill. So
Oh, sorry,
thank you
Judy.
very much, Dr. Rosenthal. Thank you.
Thank
One of
you.
one of the most interesting talks I've heard. Thank you.
We did get one more question, Judy.
Oh, okay.
Yeah,
what is it?
I was just responding right now. Yes, would everything other than the meds be the same advice for other cognitive decline? Yes, absolutely is the answer to your question. So the idea is that if, for folks on the call who don't have Parkinson's, the advice is the same in terms of how can we all do our very best to keep our cognition as sharp as possible as we all inevitably, hopefully, get older. That's the idea. Yes.
Oh, we got a lot of thank yous here.
Well,
Oh,
yeah,
I'm just gonna
thank you
read
all.
these because this is nice. Really great talk. Can the survey be emailed? Yes, it can be. Yes, we can send the survey. Yeah, fantastic. Thank you so much. Great webinar. Thanks. Thank you so much. Terrific. Excellent. Thank you. Thank you. The best webinar I've
Thank
listened to
you.
so far. I would agree. Just great. Thank you.
Well,
Okay,
thank
so
you guys
Michael,
very
now what happens? Now you do the survey?
Yep. So we're gonna end the webinar, and there should be a survey that pops up on the screen. And everyone that signed up and registered, I will also email out a copy of the survey, just in
Okay.
case.
We go. So what do we have? We don't have to do anything, right?
That's it. We can just
Pop up.
say thank you and thank you guys.
All right, thanks, everybody.
Thank you.
Now we'll see what happens.
All right.
Thanks,
All right.
thanks.
Fill out the survey, everyone. Take care. Bye-bye.
Thank you.
Thank you.
Night.
Thank you. Good night.